Thank you all for joining today for our special PEAC session. We have Dr. Maritza Harper, who is an assistant professor of internal medicine and pediatrics at the University of Pittsburgh School of Medicine in the Division of Pediatric Hospital Medicine and General Internal Medicine. Dr. Harper earned her Bachelor's of Arts and Bachelor of Science degrees from Columbia University and completed medical school in New York at Weill Cornell Medical College. She was also a general medical officer in the United States Navy before completing her internal medicine and pediatrics residency at Thomas Jefferson University, Nemours Children's Health, Delaware, and Christiana Care. She was selected as an internal medicine chief resident at Christiana Care and worked during that time as a med-peds hospitalist, and then came to UPMC Children's Hospital Pittsburgh, yay, to complete her pediatric hospital medicine fellowship. Maritza's clinical and research interests include resident medical education and clinical reasoning curriculum, and she's here to present her dissertation. And I will let her go ahead and start with her title and description from here. Thank you so much, Dr. Harper. We're excited for you to present and to learn about your work.
Dr. Spears, thank you so much. Good afternoon, everybody, and greetings from UPMC's Shady Side. I wish I could be there with you at Children's, but at least this is the next best thing. As Dr. Spears provided my lovely introduction, I am Maritza Harper, and I'm pleased to have the opportunity to share with you all my project titled Sum It Up For Me, Intern Edition, which is a novel curriculum and the synthesis of comprehensive summary statements for pediatric residents. Oh. You think after all this time I'd learn how to use Teams. Okay. I have no disclosures related to this work. If at any point, if you don't see slides advancing, if someone can either let me know in the chat or say something just so that I know and I don't just keep going. Okay, so taking you back to 2015, the National Academy of Medicine had published this seminal work called Improving Diagnosis in Healthcare. And this identified that diagnostic error was a major contributor to patient safety and acknowledged the need to address diagnostic error as a moral, professional, and public health imperative. This organization also identified these following two top priorities. One, to provide professional training and education on the diagnostic process, and two, to develop approaches to identify and reduce diagnostic error in clinical practice. This was a call to action to address improved clinical decision-making at the individual practitioner level. So I mentioned about the diagnostic process, and I want to just go through it, as I'm sure all of us have gone through this in our heads, but I want to just kind of name it. As you think about diagnostic errors and how they occur, it is helpful to break down the diagnostic process a little further. Cognitive errors in diagnosis can occur at any one of the steps in the diagnostic process. So we start off, and there's my arrow. Can you guys see my little arrow there?
Yes.
Excellent. So starting off with data collection, where you get your medical history, your physical exam, and your diagnostic testing, which is ordered. And then once you collect your data, you're going to then organize it. And then the provider or clinician is able to organize that information and develop a problem representation. This problem representation is utilized to generate the diagnostic impression and the differential diagnoses. And this impression is then compared to known illness scripts of disease presentations that then help you find your leading diagnosis that you choose it. Okay. So sounds easy going through that process, but then how do we improve our diagnostic process to reduce diagnostic error? We then want to look at what the diagnostic process is or how we decide to make clinical decisions. And as you guys can all imagine, as providers, clinical decision-making can be very complicated, and it can be multifactorial. The current dominant theory of clinical decision-making is the dual process model. And there's a picture here that I'm indicating is kind of a picture that kind of goes through this process. And so this connects two different systems of thinking. So there's the system one process, or intuitive or fast thinking, a system two, which is more analytical or slow thinking. So when we think about a patient and we are going through our processes, the system one process is the more fast, automatic processing that uses minimal cognitive effort, and it's kind of hardwired, and it relies a lot on pattern recognition and experience. There's not a lot of specific reasoning here. It's a lot of times reacting to certain identified patterns. This is often accurate. However, it is prone to error. And there are biases that can lead to these errors, which are just inherent to human judgment. Whereas the second method of decision making is the system two, or the analytical process, which tends to be slower, more cognitively demanding. It's more deliberate. There's more rationalization, and it inherently is more accurate than intuitive processes, and it can be more valuable when you're thinking about things that have a higher complexity. So, as we stated, the diagnostic process can be quite complex, but the one pivotal step in this diagnostic process that's been identified is the generation of a problem representation, which leads to the summary statement. And so this referenced paper by Olson et al. Identified 12 key competencies to improve diagnostic quality and safety. And as you can see from this little table here, the formulation of an accurate problem representation expressed in a concise summary statement is the number 2 competency for individual providers. Some of you may recognize Dr. Andrew Olson's name either from his clinical reasoning work, or most recently, if you follow Dr. Saba Fatima, who's a pediatrician who does the Muted in Medicine podcast, her most recent podcast on February 18th had a conversation about diagnostic error with Dr. Olson. And shout out to MedPeds. He's also a MedPeds hospitalist at the University of Minnesota. So I've said a couple times about problem representation and summary statements, and I'm very sure that many of you have heard these terms, but I want to just make sure that I clarify what I'm referring to. You often hear that they might be interchanged and they are the same, but I want to be very explicit. They are not exactly the same. Before we go any further, I want to just kind of label and name these two concepts. So a problem representation is best described as the mental categorization model of a patient's medical conditions that clinicians develop during the patient encounter. Whereas a summary statement is that external expression, either written or spoken, of this summative problem representation, which is a concise summary that highlights the defining features of a case, which facilitates generation of a focused differential diagnosis. Some of you may think of a summary statement as a one-liner, and ideally a summary statement should be about one sentence, but can be about 1 to 3 sentences. And so then thinking about a summary statement and how that compares to an assessment, again, related but not exactly the same. An assessment is a comprehensive evaluation of a patient's health, where a summary statement can be included in an assessment. Assessments tend to provide more of the differential diagnosis and a discussion of the patient's condition. So getting back from our kind of clinical reasoning terminology and getting back into pediatrics. So again, I'm talking to the PEAC group. So you guys are probably very familiar with the ACGME and the most recent pediatric milestones. The milestones were most recently updated in 2021, and it now emphasizes the progressive monitoring of trainees' proficiency of their clinical reasoning skills through their training. As stated by Smith et al. In their work, where they devised a rubric to assess the quality of written summary statements. The ability to create a concise summary statement can be assessed as a marker of a trainee's clinical reasoning because it requires learners to synthesize and prioritize patient information. Therefore, development of an accurate and complete summary statement is felt to be an essential step in clinical problem solving. And again, talking to a bunch of educators who work with trainees, some of you may have a similar experience if you ask some of your trainees to devise a summary statement for a patient. You may hear, Sammy is a 4-year-old kiddo who had 1 day of fever. Mom reports a rash on his arms and his back, and he's drinking okay. I think that this may be Kawasaki's disease. Or you may consider, or you may hear that Anna is a 6-year-old female and she has 6 months of bloody diarrhea and weight loss. I think that this is viral gastroenteritis. And again, talking to a lot of providers and pediatricians in the room, many of you might be thinking, wait, Maritza, hold on a second. These summary statements don't seem to accurately match the illness scripts for these diagnoses. So we're missing there's a disconnect. And while there have been numerous clinical reasoning curricula that are developed for medical students, internal medicine trainees, and emergency medicine trainees, there is scarce published training for pediatricians, specifically regarding guidance on formulation of a summary statement. Therefore, due to the lack of formalized training, trainees have challenges correctly synthesizing case details to develop an accurate and concise summary statement. Given that there is a clear need for teaching this important skill to pediatric trainees, we've designed a novel educational workshop that's designed to introduce clinical reasoning concepts specifically to pediatric interns to provide opportunity for skills practice. Intern year presents an ideal time to receive education on this foundational skill, given that most medical schools lack dedicated curricula for clinical reasoning skills, and familiarity with this terminology and practice with this skill may serve as a cognitive scaffolding for further refinement as they progress through their residency training. So the lack in available curricula led to the following aim. Developed a novel case-based curriculum based on the principles described in the Internal Medicine American College of Physicians Teaching Clinical Reasoning text. Our hypotheses were that attendees' participation in this curriculum would lead to increased confidence in development and assessment of summary statements. We also hypothesized that there would be an increase in the skill of generating written summary statements, assessed objectively by the validated rubric described by Smith et al. Prior to and after this curriculum. The goal of this workshop was to create a session that was efficient, easy to administer, and required minimal facilitator training, but yet remain effective at improving knowledge and confidence and at teaching of an essential skill. Again, I've mentioned the teaching clinical reasoning text a few times, but I recognize it's a text for in internal medicine that's commonly used. In pediatrics, it's probably not as well known. So I want to just go through what I'm referring to. The summary statement framework consists of 3 components, and it's recommended that a concise and accurate summary statement should include the following. 1, the clinical context. There we go. The clinical context that's provided pertinent demographics and risk factors about a patient. Second, there's my mouse. Temporal pattern of illness, providing length and tempo of symptoms, and then described using semantic qualifiers. And 3, identifying the key clinical signs and symptoms, or identify the clinical syndrome. And this is kind of where illness scripts may come into play. So when we think about the patient presentation or the signs and symptoms that we're putting together, it's important that the pertinent information is transformed into the appropriate medical terminology and synthesize the data into the appropriate clinical syndrome. So for example, if we see an infant and we see that their heart rate is 200, this should be interpreted as tachycardia, not just the heart rate is 200. And in another example, if A provider sees a patient who has the signs and symptoms of fever, tachycardia, hypotension, altered mental status, and cold extremities. This should be interpreted as septic shock. I want to just take a moment to make sure that we're all on the same page when I mentioned the word semantic or the term semantic qualifiers. A semantic qualifier is an adjective or adverb which describe a clinical sign or symptom, which allows providers to classify information and compare and contrast diagnostic possibilities. These are terms that are often used in clinical reasoning to provide additional context and precision to medical information. The benefit of using semantic qualifiers in summary statements is that they allow for clear communication between clinicians and they add differentiating power to the summary statement. And I've given some examples of semantic qualifiers, which I'm sure many of you have used in your clinical work. So our methods. This innovation was designed as a case-based conference for first-year pediatric residents. The short didactic session described the importance and purpose of a summary statement. It delineated the three components of the summary statement, which I discussed previously. It introduced the concept of semantic qualifiers, and it provided examples of how to improve one summary statement. After this short didactic session, participants were divided into small groups, review cases, and to evaluate and improve summary statements. Each small group was led by a facilitator who provided explicit commentary to improve and enhance the summary statements for each case. Facilitators for this program participated in a 45-minute virtual training session where the session materials were reviewed and they had opportunity to provide feedback of the case materials and ask questions. It was imperative that we included relevant skills practice based on the framework of example-based learning, which is defined as the process of learning and acquiring a skill by observing examples or models of that skill, as this has been found to be effective for learning clinical reasoning. The session ended with teaching points, which underscored the importance of a summary statement creation and specific components needed for accurate and concise summary statements. A survey was used to assess knowledge and confidence in development and assessment of our summary statements prior to and after the curricular session. A pre and post evaluation design was utilized to achieve these aims. Prior to and after the didactic content and small group session, participants were given a 6-question survey assessing their confidence and their knowledge. The confidence questions were assessed using a 5-point Likert scale for each question, where 1 indicated not confident at all. There's my mouse. And 5 indicated extremely confident. The knowledge question assessed the expert recommended components of a summary statement here. And the final task asked participants to review a pediatric case and write a summary statement based on this provided case. The case used for assessment was piloted with a group of pediatric chief residents and the study authors prior to its use in this project. Regarding the skills assessment, as I mentioned previously, we utilized the validated tool that was described by Smith et al. And we used the summary statements that were derived before the session and after, and we scored it based on this rubric. This figure that I'm indicating here is a part of the validated assessment, and it demonstrates the 5 components that were assessed for the written summary statement. This includes the factual accuracy and scores 0 to 1, the appropriate narrowing of a differential diagnosis, which is scored 0, 1, and 2, the transformation of information, scored 0, 1, and 2, use of semantic qualifiers, scored 0, 1, and 2, and then the overall global rating, scored 0, 1, or 2. And the sum of the scores of each of these 5 components ranges between 0 and 9. This suggests a higher score would have a more accurate and complete summary statement, where a lower score, of course, would not be as complete. The two study authors independently evaluated the blinded summary statements written by the participants of the session. The total scores were averaged for statistical analysis. The confidence and knowledge scores were compared using a one-way Wilcox-Unsigned rank test, and the mean skill scores were compared using a one-way paired t-test. So this 1-hour session was performed twice early in the 2023-2024 academic year, and it was a part of the weekly intern boot camp. The pediatric residency that year consisted of a total of 42 trainees, and between the two sessions, there were a total of 36 individual participants. Excluding medical students and visiting non-pediatric residents, a total of 24 UPMC first-year pediatric trainees participated in these sessions. This project was appropriately powered to assess our hypotheses. So, sharing our results. As mentioned, we looked at just the general knowledge of the expert recommended 3 components of a summary statement, and we found that prior to the session, 80% of the participants, or 19 out of 24, knew the 3 recommended components prior to the session. Whereas afterwards, we saw a 26% increase where 100% of the participants, all 24, recognized the 3 recommended components of a summary statement. This was a 26% increase, as I mentioned, and this was considered significant with a p-value of less than 0.05. There we go. Moving on to our confidence in our skills, looking at the confidence in developing a summary statement pre and post curriculum, we found a 33% increase in confidence, which was considered significant using the Wilcox-Unsigned rank test with a p-value of less than 0.05. We also found that the confidence in assessment increased between pre and post curriculum by about 33%, which is also considered a significant increase. So the most exciting part of our project was that with looking at the skills assessment. We found that using this curriculum showed a significant improvement in the skills. So as mentioned, using the validated rubric tool, that we looked at the scores before the curriculum, where the mean was 4.4 with a standard deviation of 1.47. And then after, the mean score post-curriculum was 5.6 with a standard deviation of 1.34. And we found that using a one-way paired t-test, that there was a significant improvement from this finding. And I want to just make sure, given that there was 2 study authors who blindly identified these summary statements, the percent agreement between the 2 study authors was 53%. Okay, so moving on to our discussion. This study demonstrates that a short, impactful curricular intervention based on the principles of example-based learning can result in improved skills in the summary statement generation, in addition to improved knowledge and confidence in the synthesis of summary statements. Our workshop also improved the resident knowledge about summary statement components. However, we do want to express caution in concluding that this improves diagnostic accuracy. For example, through the use of semantic, forgive me. For example, although the use of semantic qualifiers and experts has been associated with improved accuracy, other studies have shown that simply teaching novices or early learners to use these words does not clearly improve diagnostic expertise at their level. However, keeping this in mind, our data is still considered to be promising because the knowledge about clinical reasoning terms can help form cognitive scaffolding for further learning. Also, we demonstrated a statistically significant improvement in self-reported confidence in creation of summary statements. Notably, there was already a relatively high level of confidence prior to the curriculum, which is consistent with prior studies of residents at the beginning of their training. Though confidence and competence do not always correlate directly. Our results regarding the skills acquisition from this curriculum may also provide some support to improve competence with this skill. The significant quantitative improvement in skills using the validated tool by Smith et al. Demonstrates that a short, impactful didactic intervention can improve clinical reasoning skills. To our knowledge, this project represents one of the first effective curricula for explicitly teaching a clinical reasoning skill in pediatric graduate medical education. Though there have been other educational-based studies in clinical reasoning, none focused explicitly on summary statements, and none were specifically targeted at pediatric residents. In addition, an attractive feature of this curricula intervention is that it required minimal time for facilitator training, which makes it easy for educators to integrate this session into pediatric residency training programs and as a part of their regular didactics. This innovative case conference-based educational intervention is an effective tool with which to teach pediatric residents explicit clinical reasoning skills and has the potential to serve as a foundation for future curricula. Acknowledging some limitations of our study, it was only held with the pediatric residency here at Children's, and the sample size is relatively small, which of course limits our generalizability. And also, this specific curricula was only held once during the year. And so it's hard to determine the longitudinal retention at this time. So next steps that I hope continue on with this clinical reasoning curriculum is I'm working on developing a longitudinal curricula that addresses other specific skills in clinical reasoning, and also hoping to develop a clinical reasoning curriculum for pediatric faculty members to enhance and reinforce the learning that our pediatric trainees will get. I'd also like to expand this intervention at other either residency programs or other training sites. And the goal is to have this curriculum published to allow for other residency programs to use or other pediatric training programs to use. If you guys remember nothing from my time talking with you all, I hope at least you can take home these couple points. First, diagnostic error is a major contributor to patient safety, and that this can be improved by providing training and education on the diagnostic process. Second, problem representation is the mental model that a provider develops where a summary statement is the spoken or written, just want to clarify the difference between problem representation. Problem representation is the mental model that a provider develops, and in comparison, a summary statement is the spoken or written expression of the problem representation. They are not the same. And I want to just highlight that a summary statement should be concise, and it should highlight the three components: the clinical context, the temporal pattern of illness, and the key clinical findings or clinical syndrome. And then lastly, that a case conference-based educational intervention that focuses on the assessment and development of summary statements is an effective tool to teach pediatric residents explicit clinical reasoning skills. Here are some of my references from this presentation. I just want to say thank you again to everyone who's here and took the time to hear my presentation. But specifically, I want to thank Mu Yao Lin, who was my statistician and who helped assist with all the statistical analysis for this project. My primary research mentor, Eliana Facino. I want to just thank the residents, chiefs, and the faculty who served as facilitators for my session and provided feedback. I want to thank my PEDPEDS family here at UPMC, and as well as my PHM family, who's mostly here on the call. And then lastly, the program directors for our pediatric residency program who supported this initiative and have committed to incorporating a formalized clinical reasoning curriculum into their residency education. I really want to thank you all for your time and attention, and I'm happy to answer any questions.